Hello, everyone. Thank you so much for joining us tonight for the ASPN Temporary 60-Day Peripheral Nerve Stimulation Guidelines webinar. We're so happy to have you. We're going to give everyone a minute or two to log on, and then we'll be right with you. Thank you.
Hi, everyone. Good evening, and thank you for joining us tonight for another edition of the Aspen Young Innovators Journal Club. Tonight, we have the pleasure of having many esteemed colleagues join us for this great webinar on the use of and discussion of the Aspen Temporary 60-Day Peripheral Nerve Stimulation Guidelines. As always, thank you to our sponsor, Sprint, for tonight, and we have a great cohort of physicians with us. Thank you, SPR. And we have Dr. Schnur, Dr. Francio, Dr. Latif, Dr. Gill, Dr. Lawandy joining us tonight, and we'll take it away.
Hey everybody, this is Vinny Francio here, co-chair of the Young Innovators. So we are hosting the Journal Club tonight with the temporary 60-day PNS guidelines. We have a stellar panel with many authors of the guidelines that were recently published in June. So I hope you enjoy. I really want to shout out again to our big sponsor, Sprint SPR, for hosting the webinar here. And I hope you find this educational and you can use some of the clinical approach to your practice. So with that, appreciate you joining us tonight. And Dr. Gill, please take it away.
Well, thank you for that introduction. I'm Dr. Benjamin Gill, and it's my pleasure to be invited here this evening speaking on behalf of the Young Innovators Committee, as well as I was the lead author on this recently published manuscript for 60-day guidelines as published by the Aspen committees as part of the Neuron Project. And so we have several of the authors that wrote this with me, Dr. Latif, Dr. Schnur, and Dr. Lawandy also, that were invited to present this information in some cases. My role this evening is to really give us a brief foundation on the history of peripheral nerve stimulation, why we're doing 60-day treatment, as well as some of the reasoning for why the guidelines were actually published. And then my co-authors are going to go ahead and give us some more depth to the mechanisms, as well as some cases and some pearls on how you can implement it in your practice. Next slide, please. So as we look back in the history of peripheral nerve stimulation, we start around the same time that the concepts leading to spinal cord stimulation were really developed. So back in the 1960s, there was this focus on, well, what is leading to the pain signal transmissions from the periphery through the spinal cord and up to the brain, leading to that perception. Over the 1960s into the 1990s, really, most of the focus was on dorsal column spinal cord stimulation. That's what dominated the neuromodulation research. And PNS was largely stagnant throughout that time. We give credit more to Dr. Weiner and Dr. Reed in 1999, who revived peripheral nerve stimulation in application specifically for occipital neuralgia. And so their studies looked at a diagnostic block, a short trial, and then implantation of a permanent IPG for treatment of occipital neuralgia. From there, we started to get a rapid evolution in many aspects of medicine and pain medicine as far as technological abilities. In particular, ultrasound guidance was developed. And then from there, the opportunities for percutaneous coil leads, temporary external pulse generators, and all of these concepts of, well, let's move to less invasive and overall safer approaches. Around 2017, we had the commercial launch of a 60-day PNS system, and that's what we're going to be talking about this evening. A few milestones in June 2021, it was the 5,000th treatment of 60-day PNS. In May 2022, the 10,000th treatment, and by July 2024, 30,000th treatment using this system. Let's go to the next slide here. So understanding that there are three paradigms in peripheral nerve stimulation throughout its history. There's the idea of trial leading to permanent, an implant without a trial, and the 60-day percutaneous approach. And so these are three distinct pathways that we can explore and might have a role in your patient's population. The 60-day percutaneous treatment specifically is an FDA cleared application, as we'll show you a helically coiled monopolar lead that's designed for an extended stimulation trial or treatment, then removal. And in most cases, you'll see durable relief that we will also discuss. Previously, peripheral nerve stimulation typically used cylindrical leads, more similar to what we see in spinal cord stimulation. And there was concern for migration and infection risks and so forth associated with that. Next slide. As I alluded to, this is the technology that we're looking at in our modern times now. We have this fine wire with an open coil lead design, and we're able to communicate with that using our small system here and affect different programming changes for the patient. Next slide. So this approach is designed to be non-destructive, not use a permanent implant, and really, we're avoiding medications and in often cases sedation even during the procedure to accomplish this treatment. So peripheral nerve stimulation continues to evolve rapidly, and we have applications, as we'll see, from chronic back and shoulder pain to post-amputation neuropathic pain, but there's still a lot of confusion among clinicians regarding the three different approaches and how they should really go about treating their patients in an optimal way. So therefore, going back a couple of years, this idea for these guidelines developed, and we put together a large multidisciplinary author group with physiatrists, anesthesiologists, and neurosurgeons. And this initial paper that we published is really the foundation and the defining point for saying, okay, this is where we're at this point. Even throughout this year and since June, when the guidelines were released, we've seen additional publications already come out. So the idea, next slide, is that this is more of a living project, meaning it can evolve and be added to over the coming years, specifically as we still see some RCTs, registry data, and real world outcomes that are continuing to be published and emerge periodically. Next slide. Specifically in these guidelines, you'll see more information than I was able to provide this evening regarding the history, mechanism, and the rationale for this approach, and the role of 60-day therapy in multiple conditions, including chronic low back pain, chronic neck pain, chronic post-shoulder pain, or shoulder pain, both in operable and inoperable sort of conditions, knee pain, foot and ankle pain, neuropathic pain more generally when there's two or more nerves involved, occipital neuralgia, and post-amputation phantom and residual limb pain. So kind of a smattering of the pathologies that we see. I do want to specifically state that the 60-day therapy is FDA approved for chronic intractable pain, post-surgical and post-traumatic acute pain, and symptomatic relief of post-traumatic and post-operative pain. And it does not specify by indication. Next slide. As you explore this therapy in more depth, aside from our guidelines publication, I would encourage you to also look at this website here, where there's an archive of all of the published publications to date, including many case studies and RCTs and registry data and so forth associated with this therapy. It's very well designed and up to date. And on that webpage, you'll find our ASPN guidelines as well as publications before and after that. Next slide. I'm going to turn it over to one of my co-authors again, Dr. Lawandy, who's going to give us some more information regarding the mechanism of this approach.
Thank you, Dr. Gill. My name is Dr. Mark Lawandy. I'm a pain fellow at Northwell in New York. I'll be further discussing the consensus guidelines. Next slide. So referring back to Dr. Gill's slide, a trial typically lasts 7 to 10 days, no more than 10 days due to the risk of infection. 60-day PNS treatment is a temporary treatment. Traditional trials are short because cylindrical percutaneous leads have a high infection risk beyond that 7 to 10-day period. Coiled leads, which are used in the 60-day treatment, reduce the infection risk about 25-fold. This allows us to do the 60-day temporary treatment period. Overall infection risk at 60 days is about 0.1%. Next slide. So to understand why we do the 60 days, we have to understand what a responder and a non-responder is. So a responder is a patient who achieves greater than or equal to 50% pain relief. An early responder is a patient who reports achieving that pain relief of greater than or equal to 50% within the first 2 weeks and sustains it throughout the 60-day treatment period. A delayed responder is a patient who reports less than 50% pain relief within that first 2 weeks, but ultimately achieves that level of 50% of pain relief before the end of the 60-day treatment period. In the non-responder category, an early non-responder is a patient who never achieves that 50% pain relief during the treatment period. And then we have a delayed non-responder, who's a patient who achieves greater than or equal to 50% pain relief within the first 2 weeks, but ultimately falls below that 50% pain relief mark by the end of the 60-day treatment period. Next slide. So looking at this graph from a paper from Naidu in 2022, a 60-day peripheral nerve stimulator treatment allows for a longer stimulation period than the traditional 7 to 10-day trial, which helps improve patient selection. And the way it does this is so. So based on this study, we had 30% of patients who were early responders, meaning they achieved that pain relief within the first 2 weeks and continue to have that pain relief. And then we have another 31% of patients who are delayed responders, meaning that it takes greater than the 2 weeks period for these patients to experience that level of pain relief. So if we only provided patients with the traditional 7 to 10-day period, we would miss the 31% of patients that would benefit from the PNS treatment if they had a longer treatment period. We also have a rate of 7% of patients who are delayed non-responders, meaning that the treatment initially provided the 50% pain relief within the first 2 weeks, but then the pain relief fell below that 50% mark within the 60-day treatment period. So these are the patients who would have experienced a benefit from the traditional trial of 7 to 10 days, and then would have undergone unnecessary permanent implantation. So altogether, the 60-day period allows us to capture that extra 31% of patients who are delayed responders and also avoid the 7% of patients who are delayed non-responders. Next slide. There's also potential cost savings associated with the PNS treatment. So we have 2 separate health economic outcomes research publications that suggested that the use of the 60-day PNS may result in significant cost savings. On the left here, we have Dickerson from 2025, who found that starting with 60-day PNS treatment, as opposed to the 7 to 10-day trial, results in an average savings of about $7,000 per patient. And Chet et al. In 2024 found that utilizing the 60-day PNS treatment, as opposed to the standard of care for chronic low back pain, is projected to save about $8,000 per patient for the first year alone. Next slide. So here we'll start to discuss the mechanism of action as well. So we now understand a little more than just the gate control theory. So the conditions we're treating cause chronic peripheral nerve inflammation, which leads to hyperexcitability, which then leads to abnormal afferent signaling. Over time, this drives central sensitization in the spinal cord and brain. The short-term 60-day PNS treatment may reverse those maladaptive neuroplastic changes, which explains the benefit we see even after we remove the leads. Next slide. We also have So with chronic pain and central sensitization as a part of the mechanism of action, we have clinical evidence of CNS sensitization, which is often cited as a dominant pain mechanism in a large portion of the chronic pain population. Central sensitization is associated with the following: higher pain intensity, widespread pain, worse prognosis, and lower quality of life. We also find altered sensory functioning and augmented central pain processing. We find elevated levels of inflammatory biomarkers, which affect central pain modulation, and we see a reorganization of the somatosensory and motor cortex. Next slide. So we have painful and non-painful signals that go to the brain, and they become unbalanced after some types of injury or disease, which causes regions of the CNS to become hypersensitized to pain. There's a rebalancing of the inputs to the CNS, which is proposed to help treat that chronic pain by reconditioning maladaptive plastic changes. So the 60-day PNS is proposed to recondition the CNS over the course of treatment period with the goal of producing sustained relief. Next slide. We find that we have both 100 Hertz stimulation, which is intended to activate the large diameter sensory afferent directly with the goal of producing comfortable stimulation evoked sensations in the target region of pain. Next slide. We also have 12 Hertz stimulation, which is intended to activate the large diameter sensory afferents, both directly and indirectly, through the efferent fiber activation and resulting cycling muscle tension. That efferent stimulation is used as uses muscle as a translator to indirectly activate the afferent fibers. Next slide. And finally here, we have a summary of the consensus opinions regarding the 60-day PNS. This is a chart directly from our paper. So here we'll see we have strong evidence, moderate evidence, and weak evidence. Some of the things we have strong evidence for are chronic low back pain with centralized contributions, phantom and residual limb pain, post-amputation pain. We also have moderate evidence for conditions such as neuropathic pain, occipital neuralgia, and we have weak evidence and support for chronic neck pain and chronic shoulder pain versus shoulder surgery. That's it for me. Next up is Dr. Latif.
All right, hi everybody. Thank you for joining us. I'm just going to do a quick reminder that if you have questions, you can put them in the chat box and we will try to address those at the end. I'm Usman Latif. I'm an associate professor in the Department of Interventional Pain and Anesthesiology at the University of Kansas. I have a strong interest in the area of PNS. I started out actually, I did 7 years in internal medicine, retrained in anesthesiology at Johns Hopkins, did my fellowship at the Harvard MGH program. And since I've been in practice, maybe a little over a decade, I've published a lot around PNS, new techniques, new indications. I was an author on the 60-day guidelines, and we have the new overall PNS guidelines coming out in a few weeks, on which I'm the lead author. I have some disclosures here. Everything we're going to talk about today is either from my clinical practice or based on literature that I'll share with you from publications. So the first case I want to talk about was, we're going to kind of go through a couple of less common indications or uses of PNS, just to show the diversity and range that you have with the system, especially given the very small profile of the needle and the ability to reach a lot of targets very easily. This is a 67-year-old female. She has a history of some other comorbidities. One of the things is she did have a history of prior breast cancer, and this is interesting because this presumably she may need more serial imaging of MRIs or things like that in the future potentially. And so if we can offer some type of intervention that doesn't give her long-term restrictions or conditionality around MRIs, there potentially could be some benefit to that. She came in with 5 years of pain in her genitalia, in the perineum, and in the buttocks, and it was worse with prolonged sitting. Now, this isn't necessarily something that kind of is a gold standard for that, but it is very common when people have pudendal neuralgia that if they sit for a long time, they'll declare that that will increase or aggravate their pain. She wasn't having any kind of lower extremity radicular pain, and as is often the case with patients who come in with pelvic or abdominal pain, she'd had lots of workup already done with gynecology and neurology and had not really made any progress. Let's go to the next slide. So they'd even done some type of bladder surgery, didn't really improve her pain at all. And she'd been through a wide gamut of nerve blocks, pudendal, genitofemoral, superior hypogastric plexus, even ganglion impar and sacrococcygeal ligament injections, and none of them provided her relief. She went through a lot of different multimodal therapies. Now, one of the interesting points I think to make about these injections is just that if you have a very clear idea of what you think the diagnosis is or what you think would be a really great target for PNS, it's great to try to do different injections and see if you can hang your hat on something that makes sense to you. But don't be dissuaded if everything kind of fails. There is a good study from Chelsea Hoffman and Ryan D'Souza out of Mayo that looked at the predictive value of diagnostic injections. They found that there is not necessarily good short or long-term predictive value of injections for the success of PNS. And so what that means is numbing up a nerve is not exactly the same as stimulating a nerve. And so in this case, after we kind of went through all this, we kind of hit this wall. We said, you know what? We started out thinking this was pudendal neuralgia. Let's go after that target. Let's go to the next slide. So pudendal, I'm just shamelessly plugging one of our articles here. I published a technique for pudendal nerve PNS. And one of the things we did, we tried to kind of standardize and provide really clear guidance on exactly the optimal place to place a lead. And part of this was supplemented beyond the patients that we had done this on with anatomical study with a professor from that department. Let's go to the next slide. So the first step is positioning and getting that picture. So you basically start with your fluoroscope in AP, down in the pelvis area. Patient is prone. You then go 15 degrees oblique ipsilateral, the same side that you're working on. If at that point the ischial spine, which we'll look at here in a minute, doesn't become visible, you can give it just a tiny bit of caudal tilt. And then what I usually like to do is I will take a pointer and a marker, and I will kind of draw that ischial spine, which basically looks like a wide base triangle with the point headed medially. And I'll kind of draw that on the skin, pick a point a little bit cephalad from that, and after numbing up the skin, that's usually where I'll enter. So I end up going cephalad to caudad. Let's go to the next slide. So here's a picture here. You can see down on the lower right-hand part of that image, there's kind of a wide base triangle with, you can see that faint line of the triangle's sides going up towards that needle on the top and then again on the bottom. And the point where those meet is just medial to where the distal part of that needle is. So the technique essentially is you walk your way down and you land just a little bit cephalad of where that needle tip is right now and touch down on bone at the very cephalad edge of that ischial spine. And then you just let up, drop the angle a little bit, and then just slide forward a little bit. Then you let go, you drop the angle a little bit, you slide forward a little bit. And what that does is you're basically walking your way across and becoming more and more flush between the muscle and the ligament and the bone there. The other thing you're doing is each time you're releasing, the needle will actually retract just a little bit. And so this, by doing this kind of multiple times, what you'll find is you eventually make it all the way to that kind of southern edge, the caudal edge of there, and go maybe a millimeter or two past it, and then it'll actually stay. Let's go to the next slide. And so here you can see the similar type of placement on the other side. And then let's go to the next slide. There we go. And there you can see that faint lead in place right where we wanted it to be. So this patient had been through more than a decade of treatments, had really been very, very frustrated with her pain control. And after we did this, had actually 75% pain relief. She said this was the first thing that had really given her relief, period, in this entire decade that she'd been looking for things. And I think as of the time that we prepared this, she had gone past her 6-month mark and still retaining relief. As you know, these leads are pulled at 60 days. Let's go to the next slide. So one of the nice things too about that target is that often we have lots of treatments for lots of things, but then there's certain things that people come in with and we just have no solution for them. And that's why I think offering things like pudendal PNS is a great addition to your practice, because it allows you to really massively increase the access of patients to solutions for pains that probably were mostly a dead end. So this is another patient I had. She's in her mid-40s, has a lot of psych history, some iron deficiency anemia. She had come in with upper cervical axial pain. That was her biggest complaint. She didn't have any radicular component to it. She also had posterior occiput pain, and it was radiating anteriorly across her scalp, sometimes shooting into her eyes, associated with headaches. It was kind of intermittent episodic. So we kind of have two things concurrently here. We had axial neck pain as well as possibly some occipital neuralgia. Let's go to the next slide. So she ended up getting medial branch blocks, which she did great with. She ended up then proceeding to an RFA, C2 to 4, and she only had a few weeks of relief with that. So for about 80% relief, it was great. She was really happy with it. And then after a few weeks, it kind of started fading away, and eventually she ended up right at her baseline. She also ended up getting greater and lesser occipital nerve blocks, and the same thing. She had partial pain relief, but it didn't really last. She's also been through all kinds of different multimodal, still really not making any progress. So we talked to her about potentially doing PNS, and she wanted to proceed with that. Let's go to the next slide. So here you can see where we've placed the needles here. We're kind of at that C2-3 junction. You can see we're pretty far lateral. So here, what we're really trying to do is focus particularly on the occipital nerves, but with the placement here, we can probably capture some medial branch as well. If we were going solely for medial branch, we often be a little bit more medial as we are kind of maybe further down that needle shaft there on the left side. And when we're trying to capture some of the occipital nerve, we want to go a little bit more lateral. Let's go to the next image here. All right, there you can see in the lateral, and next image. And there's our leads in place. This patient was another one where they've really kind of been suffering with this for quite a while, had been kind of at their wit's end. And when we, at the end of the trial, they were at 85% pain relief. And she is now at 9 months and still maintaining that she has about 85% pain relief. She feels like it's really a nominal amount of pain. She often forgets that she even has the pain. So that's, I think, a pretty great progress here. Let's go to the next slide. So I think one of the really great things about this target, so you kind of can either, depending on your needle placement, target more towards the occipital nerve or towards the cervical medial branch nerves, is that these are pain conditions where we have somewhat limited options. So let's say someone comes in with axial neck pain. So, you know, you could do some physical therapy, you could do some muscle relaxers, maybe some trigger points, but really, if it's axial neck pain, you're probably gonna do medial branch blocks. Maybe you can do an RFA or some set steroid injections. And if those don't work, you kind of have run out of options. And one of the biggest issues there is that, you know, when you start thinking about, okay, what are your other options? Okay, maybe spinal cord stimulation. Well, a lot of carriers don't cover spinal cord stimulation for the neck, which is unfortunate. But the other thing is usually it's SCS for neck or low back pain is only covered for radiculopathy, not necessarily for purely axial pain. So you end up out of options. And so it's been really great to be able to use cervical medial branch stimulation for these patients, and we've been having really great outcomes for that. So Dr. Francio and myself and a bunch of our colleagues actually decided to gather all of that data and publish on it because we hadn't really seen any large publication reporting on a series of these. Let's go to the next slide. So what we found was that across the board, results were pretty good. We had about 2/3 of subjects had minimally clinically important difference, or MCID, for pain reduction. And 77%, almost 80% of patients had MCID for disability reduction as measured by ODI. Now, when we think about the fact that this is basically targeting a condition that is very, poorly treated in the sense that we have pretty limited options. And for most of the people who end up in this pathway, their other option was just to have 0% pain relief, to be a 0% responder because we had nothing else to offer them. If you can rescue 2/3 of those patients and give maybe, 4 out of 5 patients improved functioning, that's, I think, a pretty big accomplishment. Let's go to the next slide. Now, the other thing that we wanted to look at was, does it make a difference if someone has had a previous RFA or if someone's had prior surgery? One of the things you may have noticed there, this patient that we reported on had an RFA, and they were about just over 3 months out when we decided to do the PNS trial. Generally speaking, we usually recommend you wait about 6 months out, but if you look at the literature, there are some research protocols that have looked at this where they have allowed even 3 months out. So for me, 6 months is my ideal, but if the patient really doesn't want to wait, I'll make sure they get at least 3 months out before we do it. But the question is, does that lead to less likelihood of success? And what we saw was that there was a slightly lower responder rate among cervical RFA patients and slightly lower reduction in disability. That effect was a little bit more exaggerated in patients who had had prior surgery versus no surgery. But again, we still had a decent responder rate even in that post-surgical patient. So these are patients who might even have like posterior hardware, and we still went ahead and just placed the leads there. So really kind of working uphill there, but still able to get some responder rate there. Let's go to the next slide. So here you can see in the top figure here, we're essentially showing pain responder rates. And so in those patients who had prior cervical RF versus those who had no RF, you can see actually it's relatively comparable in terms of pain relief. But when we look at people with prior surgery versus no surgery, it's definitely better response in those who have no surgery. But those patients who were responders kind of within that subgroup of the post-surgery patients did do well. And it was about 40% of patients. So I think that's still something that's pretty respectable. Now, when we look at disability, we see that there's some improvement in disability in both groups. That improvement was better in those people who had cervical RFAs, still not as good as those who had cervical RFAs, but maybe less of a reduction in disability in those who had prior surgery versus those without surgery. And I think one of the things just to remember too is these are people who have hardware, they've been through a lot more. So we're definitely not kind of comparing apples to apples. So I think at the end of the day, I think what we try to demonstrate with this data is that certainly those patients who are non-surgical and are, potentially have not had an RFA or are far out from the RFA are going to be really great candidates for this. But even for those really tough patients where maybe perhaps the responder rate may be a little bit lower, this is something to consider for our patients and kind of offer them new options. Okay, let's go to the next slide. And I'm going to hand it off to Dr. Schnur.
Thank you, Dr. Latif. I am Dr. Madi Schnur, and for those of you that don't know me, I am an anesthesia-based interventional pain physician practicing out of Ithaca, New York. I did my training at MGH for anesthesia and at the Mayo Clinic, Rochester for pain. I was very lucky in that I had a great mentor, and the Mayo was an early adopter of the 60-day PNS therapy. And so I really learned from the best starting in 2018, which from Dr. Gill's slide, you can see that in 2017 is really when this therapy hit the market. Next slide. So I really wanted to cover some interesting cases I have had recently. My first case study is a 50-year-old female with post-surgical knee pain following a meniscectomy following a motor vehicle accident. She was diagnosed with possible CRPS by another provider. She described her pain to me really as a hot poker, worse on the lateral aspect of her knee, but also present medially. Past medical history, significant really for polyneuropathy as well as depression. In fact, she had been hospitalized several times for her depression with previous suicide attempts. She had tried several medications, tramadol, baclofen, and neuropathics. Neuropathics didn't work well for her pain. In fact, they made her mental health struggles worse. She had had recurrent lumbar sympathetic blocks performed by another provider prior to when she saw me. In talking with her, we discussed placing leads targeting her superior lateral and superior medial genicular nerves. And one reason why we did this is actually this patient has a long persistent history of DVT and PEs, actually even on her blood thinners. In discussion with her primary care provider felt like it was safe to actually take her off, which I disagreed with and did not feel comfortable with. And so normally I would target the femoral nerve for post-surgical knee pain. However, in a patient who I had never performed any injections myself with anxiety and mental health struggles, I didn't feel comfortable with this. And one reason is the femoral nerve is pretty big. And so when you target it for knee pain, really the medial aspect of the nerve is what you want to target. And so this is right next to the artery. And so if the patient moves or can't really tolerate it, you run the risk of injuring the femoral artery. So I placed 2 leads for her. Previously, her pain, she rated at about a 7 to 9. I saw her 7 days post-placement. and she was rating her pain a 5 out of 10, which she indicated to me she found tolerable and livable. If you look at the images on the slide, really the lead placement is a little bit superior and anterior to where I would normally want to place the leads. However, I generally start to stimulate when the stimulating needle is mid-shaft. So there's a good image on the right of that. And this patient in particular had pretty robust response. And so I made a decision to place the leads there. Next slide. So going back to the consensus paper, if you look at post-operative knee pain, you can see that there's strong evidence advocating for the use of the 60-day PNS system, showing that there is a higher certainty of net benefits if you were to utilize the system for this indication. Next slide. So a few things that I considered for this particular patient really is the joint capsule location. So one risk when you place genicular leads is a higher risk of infection, particularly if you violate the joint. And so some steps you can take to really mitigate this is you could flex the knee 25 to 30 degrees and bolster it prior to placing the leads. And then if you were able to place the leads really at the posterior part of the femoral shaft, this would make it so that you're farther away really from the suprapatellar bursa. Some other considerations of this particular patient, I felt like it would be inappropriate to take her off her blood thinner, and I did not feel comfortable placing a femoral lead for her with her on it. The other things that I've seen, not with this patient, but also with other patients, is overstimulation. So really with the 60-day PNS system, the sweet spot is really 0.5 to 1.5 centimeters away from the nerve or the nerve tissue itself. So being mindful of that and being mindful of patient comfort is always something I take into consideration. This patient, in terms of her goal, was really just to make her pain more tolerable and livable. And then, of course, some other targets for refractory knee pain would be femoral and saphenous. Next slide. For my second case study, I have a 65-year-old male who really has post-operative ankle and foot pain. He was diagnosed with CRPS type 2 after an ankle procedure. He described his pain as constant burning, really on the bottom and the top of the foot. He had noticed color changes, motor changes, and allodynia. In terms of previous medications, he had tried oxycodone, gabapentin, and Lyrica. Most of these medications had significant side effects for him and made him somnolent. He had had a spinal cord stimulation trial, and when I met him, he actually had an intrathecal pump. I remembered very clearly because when patients start to run out of fluid in the pump, it starts to alarm every hour on the hour, and it had been alarming for him for 5 days. So unfortunately, the person that was managing his pump had filled it with Prialt, and he had had quite a negative experience. And so after that, it was filled with saline, and he had had a hard time finding somebody to manage the pump. He did not want to explore other options for filling the pump, and so he elected to remove it, which I did. Soon after that, he wanted to talk about other therapies, and so we discussed placing a 60-day peripheral nerve stimulator device targeting his sciatic nerve. What is interesting to note, this patient also on blood thinners. I think sometimes we all feel like a lot of our patients have multiple comorbidities and are on blood thinners, but he could stop it. And actually, even if he couldn't, I would feel pretty comfortable targeting the sciatic nerve superior to the popliteal fossa, which is what I did. I have seen him twice, and he's greater than 30 days out with greater than 50% relief. Next slide. And so if you look at foot and ankle pain with the consensus guidelines, you can see that the support is moderate with level 1A evidence supporting the use of this. Next slide. So this was just kind of an interesting study that was mentioned in the consensus guidelines where leads were placed really for post-operative pain, specifically for ankle, shoulder, and knee pain. And it noted a decrease in opioid usage quite considerably. So something that I talk with a lot of the orthopedic surgeons to consider and hope that they take me up on that offer. Next slide. In this patient, some things that I considered, he had had multiple failed interventions. He had very specific goals. One, he wanted to golf, he wanted to walk. He was able to come off of his blood thinner, but again, I would do the procedure with him on it. In terms of needle size, this is a 17 gauge needle that we use to place the 60-day PNS system, which for most peripheral nerves, patients can stay on it, and I feel comfortable with them staying on their blood thinner. I did consider other targets more proximal to the ankle. This gentleman was very thin, and my practice is such that I'm in an HOPD setting, so I mostly am only able to place one lead at a time. So in summary, as opposed to my colleague, Dr. Latif, I'm really in a rural hospital-based system. Placement of these devices is possible really no matter your practice. And I've been doing it for over 5 years with kind of great outcomes. So I highly recommend, if you're not doing this, taking it up and picking a target that you feel comfortable with that really has good evidence for use. Next slide. And onward to Q&A.
All right, thank you everybody for such a wonderful presentation. A lot of excellent insight. We're gonna do our question and answers here. So we have some questions from the audience. Dr. Harman's gonna go ahead and ask the first few questions here.
Yeah, so the first question, thank you everyone, by the way, for wonderful discussion and case-based reviews. I can't tell you how helpful it is to have the review of the guidelines as well as these specific cases, because that's the best teacher, right? Specific experiences that are tailored to each patient. So the first question goes out to Drs. Lawandy and Dr. Gill. So the guidelines highlight several indications for 60-day PNS therapy. What are the top 3 targets/conditions with the highest level of evidence?
Well, Dr. Lawandy, I can start off on that answer. I've had a lot of folks ask me, like, where should they start? What should they go to? And we heard some excellent cases just recently from Dr. Schnur and Dr. Latif, some of which you might be thinking, oh, I don't know if I could do that myself. I would really start most folks thinking about low back pain and also knee pain, not just from an interventional standpoint, but from the evidence basis as well. So low back pain, one of the things that we can look at there is there's, for example, Dr. Gilmore published in Pain Practice going back in 2021, temporary PNS of the lumbar medial branch nerves. This was a multi-center study, really well done. And then they wanted to show the durability of that going out over time. And so they carried that out, and at 4 years, they were able to do a follow-up survey. So that was published in April 2025, still showing the long-term responder rate of many of those patients, those that were able to be contacted and still respond to the survey. And so low back pain is, certainly a very accessible treatment as far as for most clinicians, and also has really good evidence. as well as knee. And now Dr. Schnur talked about one particular knee case and a lot of great reasoning why she went to 60-day treatment therapy specifically for that patient. If you look at Dr. Gorey's study that was published in Neuromodulation in 2024, you can also see there a multi-center, randomized, double-blind, placebo-controlled trial of 60-day percutaneous PNS for those who are post-total knee arthroplasty, which has the most robust evidence associated with it, as opposed to maybe a native knee. And that's one that, again, just the evidence basis can give you a lot of confidence that you're doing the right things for patients. Dr. Lawandy, anything else on top of that?
I think you covered it perfectly there.
All right.
Dr. Schnur, Dr. Latif, anything else to add on some potential targets, perhaps for the practitioners that are starting their practice here soon? Something simple, something easy to kind of get their feet wet. Any idea?
Yeah, so I can take a stab at it, and then we'll see what Dr. Schnur has as well. You know, we kind of did a mix of things, right? So Dr. Schnur, we kind of intentionally divided it this way. She picked a couple things that were very common targets. I picked a couple things that were maybe a little bit more unusual. And the goal here was just to show you there's a wide breadth. If there's a nerve in the body, probably there's something we can do about it, right? But that being said, if you are out there starting your practice thinking, hey, I want to start implementing PNS in your practice, great. I think that's an excellent thing that you're going to bring to your patients. But don't start, you know, a lot of times that we all do like peer-to-peers and things like that where we help out people, and someone will say, okay, it's maybe my very first case, and then they'll pick some very obscure nerve and say, help me do this one. And I would say that's totally fine and I'll help you do that, but that's not the way I would recommend starting out. Pick up one of the basic things. And I think, you know, the core ones are probably going to be your shoulder, your knee, your low back. Those are really easy ones to kind of go after. I think shoulder is a great one to start with. The first one I ever did with Sprint was actually a shoulder. And what I like about it is if you're really comfortable with ultrasound, the suprascapular nerve is extremely easy to get to. If you want to add another lead onto the axillary nerve, also pretty easy. If you only like to do things with fluoro, getting the suprascapular nerve under fluoro is also really easy. And if you kind of look at the way the anatomy is, it's actually, there's a lot of safety features already kind of built into the scapula to make it really easy for you to get that there. And I think one of the other things about these kind of common targets is, generally speaking, the therapy is very forgiving. You're creating a field of about 1.5 centimeters. So you just need to be in the ballpark. You need to be somewhere in the vicinity of that nerve. You're going to do your testing. It's going to work great. Dr. Schnur?
Yeah, so one area we haven't talked about, I think we all have those patients that have really questionable buttock or very low back pain. And so some of my favorite targets are superior cluneal, middle cluneal, and I've had excellent results with them. Super easy to target with fluoroscopy. Have I tried with ultrasound? Yes. Have I been successful? No. So I do not recommend that route. But these are patients who you've tried SI joints, even lumbar facets. I highly recommend.
Excellent. Well, thank you so much for such awesome advice. I want you to go ahead and jump into some questions that we had from the audience, okay? So I think one of the questions was maybe coming from Dr. Gill's slides when you had a graph. The question here, I'm just going to read exactly what the question said. Based on the graph, by the end of the week 2 and 3, do we know whether the patient will respond or not? So I think the question here is trying to get, you know, within that graph, that pathway, when you get your kind of the 3rd week, do we have an idea if the patient is going to be a responder or non-responder? You guys care to comment on that?
So I believe you're referring to Dr. Lawandy's slides, going back to the IDU study on responder versus non-responder. What are your thoughts, Dr. Lawandy?
So the 3-week mark, I don't think has any, like nothing specific to the 3-week mark. It's really, we were looking at the 2-week mark more because the trial period is within that 7 to 10 days. So that would tell you if they're early responder, delayed responder, or a non-responder for that.
Yeah. I also tell people to give it 30 days because then I would expect really the late responders to have responded by that point. So if patients haven't responded at that point, it's highly unlikely that they're going to get relief going forward.
Great, thank you. There's another question here from the audience, which is, what is your opinion on evaluating RFA versus PNS in certain situations? Example, pudendal neuralgia. Anybody want to take a stab here?
I could take a quick try and see what other people think too. That's pretty specific. So I think this is something that people bring up a lot. And I think I don't know if there's necessarily a right or wrong answer, but I can tell you my thinking around it. And that is that destroying a nerve is not always the solution, right? I mean, we all have gotten patients, probably even say with pudendal neuralgia, where they said, oh, somebody thought it was pudendal neuralgia. We tried injection, it didn't work. I went to a surgeon, he destroyed that nerve. He went in there and cut it all up. And now it hurts worse, or it still hurts the same, right? And so I think, the way we should think about it, at the end of the day, when you're destroying a nerve, theoretically, you could make things worse. Theoretically, you're destroying a nerve, which is often the mechanism by where someone got pain in the first place. They had some injury to a nerve, right? Now, there are certain parts of the body where it's been very well studied and we have good outcomes with ablations. And an example would be medial branch, right? So that's something where we know that the incidence of worsening pain afterwards is actually incredibly low, but people do pretty well. And another example I'll give you is celiac plexus neurolysis. A small percentage of patients will get deafferentiation syndrome, where they'll actually have worse pain than they started out with, and then there's not a lot that you can do for it. So I just would kind of caution people, especially when you're going outside of the bounds of things that are very, very commonly ablated. Whereas on the other hand, if we're just kind of weighing it as solutions, right? Let's say that you say, okay, well, I have lots of experience with RF and I think it's okay. Still, I think if you weigh them on a scale, you would say, okay, then probably the 60-day PNS is probably my safer option. Why don't I try that first? And if that doesn't work, you still have RF available to you. So it hasn't kind of crossed anything off the docket.
I also haven't had really good luck getting coverage for non-usual targets for RFA, like peripheral nerves other than medial branches.
Yes.
That's a good point.
Dr. Harman Chopra?
Yep, so our next question, for arthritis, post-total knee arthroplasty. Between the two options, RFA versus saphenous femoral nerve PNS, which one would you consider to choose as the initial treatment option? Would it be more RFA or time tested, or PNS given the recent success?
I can take that. So I personally have been choosing PNS. I think there was a long period of time that I continued to target the genicular nerves in the classic areas without much success, particularly for arthritis. Better luck with post total knee arthroplasties. Really, I think to cover the needed nerves, right, which there are 10 nerves which innervate the anterior joint and 14 in total, you need to make a lot of lesions. And that takes a lot of time and a lot of effort that I think most of us, unfortunately can't give to each patient. And so targeting femoral saphenous is just better, and really femoral I think is the best for knee pain. One, because many of the nerves that innervate the joint capsule come from that nerve target.
That's a really good answer. The thing that changed the paradigm for me, and I had gone through multiple different like ablation techniques over years, different types of cannulas, different needles, all kinds of different things. And I had this 80-something-year-old lady who was in an assisted living facility, which is severe pain. She was large. She couldn't get a knee replacement in her case. So this was in the native knee still, but her BMI was up there. She had anticoagulation concerns, all of those things. And I said, look, do you want to go this like route of trying to destroy the nerves, or do you want to do the temporary peripheral nerve system? Because we can do it under local anesthetic. It can be done in about 10 minutes. We can do it with ultrasound or fluoroscopy, all of those different options. Long story short, she walked into my clinic 1 week later and I was blown away. I did not believe it. I was like, I was not expecting that good of a response. And then she was doing physical therapy at her assisted living facility every single day from then on out. right? And so by the time we were even pulling the PNS leads at the 60-day mark, she had conditioned herself so much better than I'd ever seen someone who had gone through a destructive process as far as her bounce back and her recovery and her response from then on. It really just changed things for me on how we approach this.
Excellent.
I think one other thing that I could just kind of mention is that one of the things that maybe sometimes causes genicular RF to underperform as well. In 2019, I taught the genicular RF course at ASRA, and right around that time, two cadaveric studies had come out looking at the anatomy of the genicular nerves, and what they found was that in the superior medial and superior lateral genicular are actually much more posterior than we historically thought. Rather than being kind of mid-shaft, it's almost like 90% of the way posterior. Now, most of us are not using cooled RF and making really big lesions for a variety of reasons, mostly cost related. And so when you're doing conventional RF, your lesions are relatively small. And so I think often we were just missing it. Maybe you were getting lucky in getting the inferior medial, but kind of missing on the other ones. But in the early part of targeting with PNS at the geniculars, we were doing actually genicular PNS. And I think why that was so successful, even though probably people were still just placing their needles just about mid shaft and not going posterior, is that you had the grace of the larger field size you were generating. And so it didn't really matter that much. As long as you got it kind of in that vicinity, you were capturing it. And maybe you're capturing other small branches as well that are innervating other parts of the knee.
Excellent. Thank you. Thank you so much. Well, we have a few more minutes here left, maybe 3 or 4 minutes. So I want to ask one question, maybe about 30 to 60 seconds answer, and then we kind of close it up. But the question is pretty much a question from the audience is, have you found issues with the insurance approval? And then the question that I want to ask and share, ask at the same time is, if you do, what are some of the clinical pearls or suggestions that you have for us to facilitate that optimization and get this approved by the insurance? So, question for the panelists. Thank you.
I can start off on this one. So I would say private insurance, it's about 50-50 approval rate. Medicare, Medicaid has approved it for me. In instances where I've had issues and I felt very strongly about the system being utilized, I wrote a letter of medical necessity, and actually I went to the website that I don't remember if it was Dr. Gill or Dr. Lawandy who said, look at this website, there are all these papers that are cited. I went to that website, I looked at papers for the indication, and I cited it in my letter of medical necessity. It was with, I don't know if I can say it, I'm gonna say it, it was with United Healthcare, and they then approved it, and I was able to place the leads in the patient who ended up getting good benefit.
I could give a few quick tips. So I think in terms of diagnosis, your primary diagnosis should be mononeuropathy, unspecified. Additional diagnoses that are very helpful are chronic pain syndrome and neuropathic pain. And then for number 4 and 5, you can put whatever you want that's specific. If they're commercial, I think across the board, what we're seeing success rates is about 25 to 30%. So I think it's still worth it, even if it's insurers that you don't think are covered. Just keep submitting it, put that pressure on them, show them that their patients want this. For Medicare, it's covered by NCD 160.7. So what that means is that for all your Medicare patients, there's really no restrictions. It's actually probably one of the least restrictive policies out there. It's very reasonable. The patient has to have chronic pain, and you have to have a nerve that you can target, and you can kind of proceed. If someone has Medicare Advantage, they often will try to deny it. But the nice thing is when there is an NCD, which not all procedures have an NCD, a national coverage determination, they're obligated to cover it. And they can have their own policies, but they cannot be more restrictive than the NCD. And so I'll frequently get Medicare Advantage denials, and I will always do peer-to-peers and appeal them. And I'll basically bring exactly that point to their attention, that they'll try to say, oh, did you look at the Humana policy or the Aetna policy or whatever it is? It's investigational. Say, I don't need to look at it because it doesn't apply. If you have some policy, it can't be more restrictive than the Medicare one, which has no restrictions. And I would say the vast majority of the time I'm successful in flipping those. And when I'm not, I refer the patient to SPR Care, where they will actually then just work with the patient and they'll get it approved, even if they have to take it to an administrative law judge. So I think that helps a lot.
Harman, I think you're muted there.
I appreciate that. Thank you so much to Dr. Gill, Dr. Lawandy, Dr. Schnur, and Dr. Latif for that wonderful and informative presentation. And thank you once again to SPR for the therapy sprint 60-day PNS. As always, we appreciate everyone's time. We know it's a busy time in the middle of the week to join us, but having these moments, learning about these cases is truly what helps us grow. I just started fellowship. I've done a few PNS, and I can tell you there isn't enough experience that you can get this early on to make you a better and more prepared clinician for the future. So thank you all.
Thanks everybody again for joining us. On behalf of the Young Innovators Committee, we appreciate you tuning in, and we'll continue to do our journal clubs with the ASPN guidelines that we are frequently posting out. Huge thank you to our sponsors, SPR. I want to share again the same thoughts that Dr. Latif just mentioned, making sure that when you are submitting these cases that you use SPR Care. It's an excellent resource out there to help us navigate the barriers and the difficulties that we have in clinical practice with insurance. This is an excellent therapy for a lot of our patients that need. So we appreciate you joining us. If you have any questions, you can always email us. I'll be happy to answer. And we look forward to the next journal club. So thanks again for joining us, and take care.
Thanks all.
Good night.